Good afternoon and good evening, everybody. And this is our another International IVF Alliance webinar. And today I'm so happy to have Jordan O'Donnell to give us a talk, and she's going to share her research result. And then let me give a brief introduction about her first. So Jordan has a master's degree in personalized medicine and novel therapies from UCL in London. She is a genomics application specialist at UCL Genomics and a research intern of genomics prediction. Driven by passion for bridging genomic technologies and reproductive genetics, she initiated an international collaboration for her master thesis. So investigating the relationship between embryo morphology and polygenic risk scores. This is a project has been featured at major conferences in both US and UK. And Jordan remains committed to advancing reproductive genetics to deliver patient-centered, science-driven treatments at a scale. So also I want to introduce our organization, International IVF Alliance. It was established by a group of embryologists and IVF physicians. We plan to host monthly roundtable discussion. I want to make this really open to everybody. Anyone has questions, I encourage you just raise your hand and ask your questions. So the goal of the our webinar or the talks are usually it's going to be challenging conventional thinking and share knowledge and insights, exchange ideas and foster collaborations, and connect reproductive health professionals. And today is another opportunity for us to share knowledge. I also want to take this opportunity to thank a couple of people who have been helping me to organize this webinar. So first, I want to make a self-introduction. My name is Yifei Liu. I'm the IVF lab director at Penn State Hershey. And I want to thank Wei has been helping me to coordinate the meetings, get in touch with the speakers, and she also has been getting out the meeting information out and on social media and everything. And I also want to thank Dr. Yu for providing the Zoom platform for us to host the webinar. And she is famous in the reproductive biology field because she's the program director for EVMS, Master and a PhD program. And I also want to thank Dr. Lee, and she has been helping me to issue the certificate of attendance and also the ABB CEUs. So thank you so much. And then without further ado, I want to hand over the talk to Jordan. Jordan, please take it over.
Awesome. Thank you so much for the introduction, and thank you very much to the International IVF Alliance for having me here today. I'm super excited to share my research. So I will just share my screen now. Can you guys see this? Can I just get a...
Yes.
Perfect. Awesome. All right, so thank you so much. I just wanted to mention again that this was done in part of my master's thesis in collaboration with genomic prediction. So we're super excited to share the findings of this research with you all today. And I'm glad that you mentioned challenging conventional thinking, because that is what we'll be doing. So let's dive in. So just as a brief overview of what we'll be going through today, we're going to start with the limitations of conventional embryo grading systems, so the Gardner grading system in particular. We're then going to be talking about how we implement polygenic risk scoring into clinical practice, and then more specifically, how we can use pre-implantation genetic testing for polygenic diseases. Then we'll talk a bit about the embryo health score, and this is our composite PRS algorithm that we used throughout the study. And then we'll be finally comparing this EHS, or this composite PRS algorithm, with the embryo morphology. And that will bring us into the main discussion of today of the results. So overall, today we'll be exploring the relationship between embryo morphology and polygenic disease risks. This will be challenging for the first time, this 40-year assumption that selecting embryos solely based off of embryo morphology will have no long-term health implications. So to start, embryo morphology, here we're specifically talking about the Gardner grading system, categorizes embryos based on their visual appearance and structure at about day 4 to 5 after fertilization. These embryos are assessed based on the structural appearance of the expansion status, the trophectoderm development, and the inner cell mass quality. So this method has been validated and is to correlate better quality embryos with higher implantation and pregnancy success rates. So traditionally, embryo morphology, which is guided by this Gardner grading system, has been the backbone for selection. But as genomic technologies rapidly advance, we must ask ourselves, could this visual approach actually be introducing biases and subjectivity? Now, although this is a very highly validated method to be correlated with better graded embryos with higher IVF success rates, this gold standard method does not come without any limitations. So I think this circular heat map does a great job of summing up the inter-observer bias by showing the grading of I believe around 400 embryos across 5 embryologists compared to a computer-generated algorithm. But now you can also imagine the intra-observer bias if you were to grade the same embryo in the morning, say, versus in the afternoon. But this bias, along with the 54 possible categorical variables, makes analyzing morphological data quite challenging and often uninterpretable. And aiming to standardize this, SART scoring was created, but this still yields 36 possible categorical variations. Now, the statistics side of this, of why this challenge makes this, the research quite difficult when analyzing morphology data, will become more apparent later on, but it is good to just keep that in the back of the head. Now, pre-implantation genetic testing complements morphology-based selection in roughly 1/2 of all IVF cycles in the United States, while its use globally has many different regulations, and some regions being more strict than others and many being more open. So this table just shows some different types of PGT tests that are being offered. We have PGT-A to screen for aneuploidy, PGT-A+ to find the origin of chromosomal abnormalities, PGT-M screens for monogenic diseases, PGT-SR screens for chromosomal abnormalities due to structural rearrangements in the parents. And finally, we have PGT-P, which screens for polygenic diseases. Now today, this talk will be focused on this more thought-provoking test, which is PGT for polygenic disease risks, or also called PGT-P. So now, how can we actually integrate polygenic risk scores into clinical practice in general? So the prevalence of polygenic diseases is over 10 times greater than that of monogenic diseases, and accounts for about 80% of all non-communicable diseases. Large GWAS studies have enabled the identification of associated alleles and the stratification of patients into risk groups by polygenic risk scores. Now, many studies have proven the clinical utility and success of polygenic risk scores in clinical practice, including validation of PRS for coronary artery disease. We have hypertension prevalence throughout lifetime using a multi-ethnic polygenic risk score algorithm. And we've also looked into personal and clinical utility of polygenic risk scores, for example, in the BRCA1 gene. However, the controversy comes in when we start discussing the use of PRS in the pre-implantation embryo. But research now shows that the validated polygenic risk prediction in adults can be achieved in embryos with the same accuracy. So these studies have demonstrated significant reduction in disease prevalence when choosing one of two siblings with polygenic risk scores compared to random selection. So the study investigated 40,000 siblings from the UK Biobank. Now, the expected translational benefit to IVF patients assumes that morphology-based embryo selection is equivalent to random selection in terms of polygenic disease reduction. Now, on the left here, we're talking about the embryo health score, and we'll get into it in more detail in the next few slides. But just as an introduction, the embryo health score, or the EHS, is a composite PRS algorithm. And it is a screening tool to use to provide relative risks and not used as a diagnostic test. But as you can see here on the graph on the left, it shows that the higher the EHS value, the lower the risk of developing polygenic disease is. Or in other words, the higher the EHS, the better the overall genetic health of the embryo. So now let's get into a little bit more detail on the embryo health score. So how is this actually calculated? So oftentimes, polygenic risk scores are developed and algorithms are built upon a single polygenic disease of interest. But our team of bioinformaticians have developed a composite PRS algorithm that combines all risk predictors into a general index called this embryo health score. So throughout the study, we used this as our composite PRS, and subsequently I'll be referring to it as the EHS. So the EHS is ran individually for each ancestry and can be described in a linear formula based on the combination of risk estimates with the aim of simultaneously reducing the risk of multiple diseases. Now, this risk estimate varies based on multiple factors, including ancestry, the specific condition, and family history. So again, as I mentioned before, higher index scores represent higher overall genetic health, or individuals at a lower risk of developing these long-term diseases. So this table on the right here shows a list of the polygenic diseases that are screened for on our EHS screening panel. And just briefly to show an example of how this EHS test report is used clinically, it would be sent back. So if you're ordering a PGTP test, it would be sent back to your clinician to help you decide which embryo to prioritize for transfer. So I just want to show here and point out that PGTP always goes hand in hand with PGTA. And this first report here shows that the embryo health score is computed only for the euploid embryos. And now these results are relative to the specific patient's cohort of embryos. Now, if we want to take a little bit of a closer look at embryo number 3, it breaks the score down into the specific diseases and shows, you can see the ratio here of the embryo's risk compared to that of the general population. And of course, for more information on the embryo health score just in general and the clinical utility of it, you can visit the LifeView website. So back to this research project now. Up until this point, the assumption has always been that morphology-based selection would have no impact on the prevalence of polygenic disease risk in the preimplantation embryo. Or in other words, that morphology is equivalent to random selection in terms of polygenic risk reduction. But this is the first study that actually aims to prove this assumption. So now it's time to ask, what if this relationship really isn't random? So now we can actually talk about how we tested this question. So our data came from a single PGT center in the United States, which received morphology data for each embryo from numerous IVF clinics. Now, as I mentioned before, back to the computational challenges that arises when attempting to analyze up to 54 categorical variables, we had to create this categorization system to help us better statistically analyze morphology. So we assigned numeric values to the alphanumeric Gardner grades, so for the TE and the ICM specifically. So for example, embryos graded with A's, B's, and C's corresponded to numbers 3, 2, and 1, respectively. And then summed and group clustered each of these scores into 3 categories: low, medium, and high. So this left us with the 3 categories rather than the 56 and was made our data more suitable for computational analysis. So for the lower group, the low score corresponded to poorer graded embryos, and the high group corresponds to the better graded embryos. So we then had to validate these this categorization method against established relationships that are already related to morphology, and I'll get into the specifics of that as well. And then finally, we were able to evaluate the relationship between embryo morphology and the EHS. So for data inclusion criteria, we started with over 52,000 embryos in our database, and this was gathered from nearly over 100 IVF clinics across the United States. But then we had to filter our data down based on the following criteria. So we first filtered it to only include standardized Gardner grades. We then filtered it to only include euploid embryos with cases that had parental DNA collected with it, as these are the conditions in which the EHS can be computed under. And finally, we filtered only for European ancestry due to the availability of data in the validated predictors, leaving us with a total of 1,414 embryos to use in the study. So just a quick note here about ancestry, because this is really important. As I mentioned before, the EHS is ancestry specific, meaning that different predictors are used for different ancestries. So as you can see on the table here on the right, European ancestry has the most validated predictors, but of course it is still validated for all other ancestries as well. This is just what we used for our study. So back to the categorization method now. I briefly mentioned before that we had to prove that these groups were reliable to work with. So we first compared it to the previously established relationship with within morphology. The first one being that high rates of aneuploidy correspond to poorer morphology, and which has been validated before. And when we compared our categorization method with this, we found the exact same distinct pattern with nearly 30,000 embryos. And now this one was a bit more interesting. We found that we validated our categorization method against the relationship showing that there's sex bias being skewed towards males with conventional morphology-based embryo selection. And again, when we validated our clusters, we saw the same pattern with statistical significance showing a skew towards male selection. So essentially, this is...
Can I stop you for 1 second?
Yeah, absolutely.
Like your slides are, it's kind of like falling behind. So, yeah, when you're talking about the, is that possible for you to like stop, the slides and start again and start from where you pick it up from where you stopped? Yeah,
sure.
Thank you.
No problem. Thanks for letting me know. Is this looking better?
Yep, now we're talking.
Okay, perfect. Thank you. Okay, so back to the morphology clusters and sex bias. So we essentially found here that female representation is decreasing as Gardner grades improve. which is quite interesting. So now, demonstrating the validity of these groups, we're able to begin our analysis. So this is the fun part now. So overall, we found a highly significant inverse relationship between the EHS and embryo morphology. So these results here are showing that embryos in the higher group, or the better graded embryos, had lower EHS values. So what does this all mean? This basically means that the better graded embryos were found to have a higher risk of developing polygenic diseases. Now we can say the same about the low group, showing that poorer graded embryos have higher EHS values, indicating that poorer graded embryos had a lower risk of developing these diseases. So then we looked at the EHS means across the individual embryo categories, being the expansion status, the ICM development, and the trophectoderm development. Sorry, the ICM quality. And we found that the expansion status and trophectoderm development followed the same pattern of the higher the individual grade, the lower the EHS values. But it is important to note here that although these individual grade parts were not significant on their own, it is the combined effect that is statistically significant. So now let's get into why this might happen. But first, we'll start with the limitations of the study. So beginning with the sample size, we were limited to around 1,400 embryos here, but we are currently working on expanding the analysis of this data to a much larger sample size. So keep your eyes peeled for a paper on this. It should be quite interesting. And the main one here would be the subjectivity of the Gardner grading. We did try to mitigate this effect with the grouping method. However, future studies will be including time-lapse data and integrating morphokinetics to further assess this relationship with less subjectivity. We also had to assume equal weight of the trophectoderm and ICM quality, and this was based off of previous literature and in collaboration with other embryologists. And finally, we were limited to European ancestry for this study. As I mentioned before, this was only due to the access at the amount of data and the validated predictors that we had. So clinical utility of this embryo health score. So earlier on, I discussed the sex bias that's identified in conventional morphology-based selection. And interestingly enough, the EHS algorithm actually can correct for the sex bias that's typically observed. Another point is that the EHS is a selection tool and is clinically available with the intention of prioritizing the transfer of euploid embryos. It's also important to note that PGTP, or this embryo health score, it's not intended to discard embryos, and it is not intended for the selection of cosmetic traits. Okay, so now the big question here is why? Why are we seeing this relationship between better graded embryos with poorer long-term health outcomes? Well, one possibility could be a hypothesis proposed over 20 years ago called the quiet embryo hypothesis. Now, this states that the metabolic activity in the preimplantation embryo is negatively correlated with its long-term health. Our observations are consistent with this hypothesis. However, we do, of course, want to proceed with caution and continue to validate these results, which we are still doing. So another relevant hypothesis to consider is the Barker hypothesis. And this proposes that early life conditions during fetal development play a critical role in determining the long-term risk of diseases. So in the context of IVF, some research suggests that aspects of art, including in vitro culture environment, may influence fetal development and therefore the long-term health outcomes. However, it is important to consider the counter argument to this as well. So research shows that reproductive health is closely linked with overall health in men and women, and that infertility itself is associated with a higher risk of long-term diseases. So this raises the really important question of, could this higher risk for disease be due to the IVF process itself, or is it a reflection of the underlying health conditions of the infertile population? Or a third option could be, is it possible that the selection process itself hasn't even been considered up until this point? So I'm bringing all of this up because it is important to consider the possibilities of why we're seeing these results of better graded embryos with a higher risk of developing polygenic diseases, because it is quite the surprising result. So now that we have the tools to actually ask these questions, the potential of this research is extremely exciting, in my opinion, at least. So now the main takeaway here is that according to our study, conventional morphology-based embryo selection is not equivalent to random selection with regards to polygenic disease risks. Now, although this is just preliminary, it offers a compelling new perspective on the assumption that morphology-based selection has no long-term health implications. In fact, this research actually challenges that view quite critically, and it encourages us to rethink this assumption more carefully and explore the potential long-term implications of morphology selection or the long-term health outcomes in general, now that we have the tools to actually do this. So just, I want to say a big thank you to both of my teams at Genomic Prediction and UCL Genomics. I am extremely grateful for everything that you guys have helped me with and really guided me along this path. And also just to mention that my colleagues Katie and Diego will be at PCRS in, I believe it's next month. And they are very knowledgeable in this topic and would love to be in contact with many of you. If you're there, please reach out to them. Just some contact information as well. And I'd love to answer any questions that we might have. Thank you.
All right. Thank you so much, Jordan. All right. How about we